morning. Hi, I'm Karen Van Calo. I'm the President and CEO of the Florida Healthcare Coalition, and I want to thank you for joining us here today. We are kicking off what we're calling our Better Pain Management Collaborative, and this is going to be a year-long effort to really dive deeply into the pain management issue. We've muted your lines because we've got so many people who have registered to participate. So if you have any questions or you have any technical difficulties, please chat your questions to Ashley Tate-Dinger. She's identified as the host if you are participating on this via the webinar. And what we'll do is we'll answer your questions after each section of the agenda. So pain is the most common reason that people seek medical attention. At a national, state, and regional level, efforts are underway to increase the awareness of the treatment of pain as a very complex public health and medical issue and find solutions to better manage pain. Every day, I think you'll agree with me, we hear of another tragedy that's caused by opioid addiction and abuse. And in Florida, our governor announced only a few days ago that the opioid crisis is a public health emergency. And later in this webinar, you'll hear more about this state of emergency. We recognize that addressing the problem of pain management abuse has to be balanced with the need for appropriate management of acute pain and the treatment of severe chronic pain. The task forces in Florida that have convened so far to address opioid and heroin abuse have not yet engaged, in my opinion, the employer and business community. So Florida Healthcare Coalition is throwing itself into the mix to identify employer issues and concerns related to the diagnosis and appropriate treatment of pain, but also the impact of pain on cost and productivity. Often the pain drugs that are paid for by the employer through the health plan are the patient's first contact with an opioid. We seek to increase awareness of the risks of opioid abuse and addiction and to identify and disseminate best practices, policies, procedures, resources, and approaches to better pain management with a special emphasis on those that would reduce the risk of opioid addiction. And we'll do that through identifying enhanced benefit design, education, and workplace policies. So we're going to undertake this work over the next year, and we're very grateful to our affiliate partner, Pacira Pharmaceuticals, for sponsoring our efforts. Next slide, please. Here's the agenda for our call today. To start off, we're very fortunate to have Dr. Chris Whaley from Berkeley, and he's going to provide an important level set on the opioid crisis in America's workforce. The information that he's going to present to us today comes from work that he conducted with our affiliate partner, Castlight. Dr. Whaley was the primary researcher on the study that he'll be talking about today. A very special thank you to Castlight for making it possible to have Dr. Whaley speak with us on this webinar. If you have questions on his section of the agenda, again, please chat them to Ashley, and we'll have plenty of time to answer them following his presentation. Next, I'll review the results of a survey that we did at the Florida Healthcare Coalition. We surveyed some employers here in Florida on pain management. We did this survey in March and April. So if you have questions on that part of the agenda, please also chat them to Ashley for me, and we'll address them. And then we're going to go into the work group activities that we've identified for the next year, and we're going to ask you to identify which group or groups that you'd like to engage with. We definitely need your input and your involvement as we address these really important topics. And then Lois Adams with HHCS Health Group in Orlando is our local expert on health policy, and she is going to speak to the public health emergency that I referenced a couple of minutes ago and legislative issues in Florida, and then we will wrap up with next steps. So let me go ahead and introduce Dr. Whaley now. Next slide, please. Christopher Whaley is an associate policy researcher at the RAND Corporation and an assistant adjunct professor of health policy and management at the University of California in Berkeley. His research focuses on the price and information factors that influence patients' choice of providers and the associated quality effects of provider choice. He's also examined how providers respond to changes in consumer decision-making and variations in provider quality. His research has been published in a variety of clinical, health policy, and economics journals. So we are very happy to have him with us today, and go ahead and turn it over to you. Thanks very much. So I can't hear.
Sorry.
Okay, good.
Thank you. So I'm excited to talk about opioid misuse and what employers can do. And as mentioned earlier, this is a study that I conducted with Catholic Health about a year ago. We're making the full report from that study available online. And so if you have questions, that's an easy reference. And I'm also happy to answer questions at the end of this presentation. And so, according to the CDC, nearly 2 million Americans are misusing prescription opioids, and 44 people die every day from prescription opioid overdose. That's more than the number of people who die in car crashes every day. And so this really highlights the urgency of understanding the opioid crisis and what role employers can play. And so I'm going to give an overview of some of the things that we found and some of the insights that we've been able to use a pretty novel source of data set to get at. And just as a next slide, please. And just as a disclaimer, this work is not affiliated with either the RAND Corporation or the University of California, Berkeley, and neither this presentation nor its results necessarily represent the views of either RAND or UC Berkeley. Next slide, please. And just as an overview of our key findings, we organized our findings about opioid misuse into 8 main categories: the number of prescriptions used, medical spendings, age, behavioral health conditions, pain diagnoses, patient income, geography, and medical marijuana laws. And so I'm going to talk about these main ones. And just kind of as an overview, we find that 1 out of every 3 opioid prescriptions is being misused. Opioid misusers cost employers and the healthcare system about twice as much as comparable people who are not misusing opioids. Baby boomers are 4 times more likely to misuse opioids than millennials. Individuals living in America's lowest income geographies are twice as likely to misuse opioids than those who are living in higher income areas. Patients with any behavioral health diagnosis are 3 times as likely to misuse prescription opioids. And finally, individuals with previous pain diagnoses are twice as likely to misuse opioids. And then finally, opioid misusers are more likely to live in the rural South than in other geographic regions. So that last point is particularly pertinent to the webinar today. And just kind of overall, when we look at these key findings, they're actually not that different than what other studies have found. For example, the Centers for Disease Control, or the CDC. But one of the things that is unique about this study is that while these other studies look at just the general population, this is probably the first study to look specifically at the employer population. And so within the employer population, we see many of the same trends that are happening for the general population as well. Next slide, please. So now I'm going to drill down a little bit deeper into many of these key findings. So when we look at the number of prescriptions that are misused, we find that 1 out of every 3 opioid prescriptions is being misused. And moreover, 4.5% of individuals who received any opioid prescription are misusing opioids. And so how do we define opioid misuse. So first off, for our data, we use both medical and pharmacy claims data. This data set covers about 1 million individuals who received any opioid claim. And this data comes from Castlelight Health employer-sponsored customers who provide insurance to employees and their dependents. And then from this population, we followed existing clinical measures to identify opioid misusers. And so we defined a person who's misusing their opioids as somebody who meets two criteria. So one, they have to receive at least a 90-day cumulative supply of opioids. And two, they have to receive opioids from at least 4 different providers. And so this captures both receiving a large quantity of opioids and then also some element of doctor shopping. And so while we find that 4.5% of opioid users appear to be misusing opioids, the more optimistic viewpoint is that 95.5% of opioid users appear to be using their opioids appropriately, and so that is certainly encouraging. And one way to make the distinction between the two groups, those who are misusing opioids and those who appear to be using opioids correctly, is to look at the total days of opioids supplied across our sample period. For those who we think are not misusing their opioids, the median total day supply is 7 days of opioids across our entire sample period, which actually seems pretty reasonable. However, for those that we believe are misusing opioids, the typical total day supply, so the number of opioid coverage days that they receive, is 481 days, which is almost 70 times greater, and that's fairly alarming. Next slide, please. So when we look at medical spending, we find that opioid misusers cost their employers nearly twice as much, a little under $20,000, in healthcare expenses than non-misusers who still use opioids, about $11,000. And so this is about an $8,600 difference that people who are misusing opioids cost their employers and the healthcare system. And based on our estimates, opioid misuse could be costing employers as much as $8 billion per year. And also considering that absenteeism and presenteeism tied to opioid misuse cost employers an additional estimated $10 billion per year. This crisis represents a substantial drain on employers that really hasn't been accounted for before. Next slide, please. And when we drill down to age, we find that older individuals are much more likely to misuse opioids than younger individuals. So among millennials, which we define as the under 35 age population, we find that only 2% of people who use an opioid prescription appear to be misusing opioids, while among baby boomers, the 50 to 65 population, we find that 7.5% appear to be misusing their opioids. Next slide, please. When we look at income, we find that individuals living in America's lowest income areas are twice as likely to misuse opioids as those who are living in higher income areas. So for example, 6.3% of individuals with an opioid prescription who also live in the low income areas, which are areas with a per capita income of $40,000 or less, misuse their opioids, compared to only 2.7% of individuals who live in the highest income areas, and those are areas with a per capita income of $85,000. And so this contrast is pretty stark, and really I think highlights the need for innovative thinking about how to address the opioid crisis. Next slide, please. When we looked at behavioral health conditions and individuals with behavioral health conditions, we found that individuals with any behavioral health diagnosis are 3 times more likely to misuse opioids than those who do not. For example, we find that 8.6% of individuals with a behavioral health condition appear to be misusing their opioids, whereas only 3% of individuals without a behavioral health condition are misusing their opioids. And this finding is fairly striking given the prevalence of behavioral health issues in the workforce. Other studies have found that 25% of employees have a diagnosable behavioral health condition, but 70% of these individuals don't go treated. And so I think, again, this really highlights the complexity of addressing the opioid crisis, and really highlights the fact that it's not just simply opioids. It's a much more complex system-level issue that needs to be addressed more holistically. Next slide, please. And finally, when we look at opioids related to pain-related conditions, we find that opioid misusers have twice as many pain-related conditions as those who are not misusing their opioids. And so this might be expected because we think that many people get access to opioids through pain-related conditions. So just to drill down on these a little bit more, we found that opioid misusers have a little under 4 pain-related comorbidities on average, while those who are not misusing their opioids have less than 2 pain-related conditions. The 3 pain-related conditions that are most associated with opioid misuse are joint, neck, and abdominal pain. And individuals diagnosed with joint, neck, or abdominal pain-related conditions are more likely to misuse opioids compared to other pain-related diagnoses such as pelvic, dental, or jaw, or non-fracture injury pain. And in this table, you see 2 measures of opioid misuse. And to make each measure a little bit more clear, let's start with the second column, the misuse rate. The 14.6% misuse rate for joint pain in the first row means that 14.6% of opioid users who have a joint pain-related diagnosis code appear to be misusing opioids. So again, they receive at least 90-day supply, and then also opioids from at least 4 different providers. The 43.4% in that top row for the relative share of misusers means that 43.4% of opioid misusers have a joint pain-related diagnosis. So what that means is that a little under half of individuals who we think are misusing opioids have a joint pain-related diagnosis. And this column does not add up to 100 because many individuals have multiple pain-related conditions. And so the last thing that we looked at was how opioid misuse varies with geography. We found that opioid misusers are much more likely to live in the South. And again, these findings align with findings from the CDC and other research studies around opioid misuse and prescribing behavior. 22 out of our top 25 cities for the opioid misuse rate are located in primarily rural or southern states. And so this map, you can see the top 25 cities with the highest opioid misuse rate. Opioid misuse rates range from 11.6% of individuals in Wilmington, North Carolina, to 7.5% of individuals in Fort Smith, Arkansas. Alabama, Florida, North Carolina, Oklahoma, Tennessee, and Texas have multiple cities who made our top 25 list. And the 3 non-southern cities in the top 25 are Terre Haute, Elmira, New York, and Jackson, Michigan. And of particular note, our number 3 city, Panama City, and our number 6 city, Pensacola, are in our top 25, with 11.5% misuse rate for Panama City and a 9.8% misuse rate for Pensacola. And again, keep in mind that our national average for the misuse rate was 4.5%. So all of these 25 cities, and in particular the two that I just mentioned in Florida, are roughly twice as high as the national average. Next slide, please. And so we also looked at the percentage of opioid prescriptions that are being misused. And so one way to distinguish between this map and the map that I just showed is that the previous map looked at opioid, the number of people or the share of people who are misusing opioids, while this map looks at the volume of opioid prescriptions that appear to be misused. And so just again as reference, nationwide, we found that about 4.5% of individuals are misusing opioids, and this 4.5% of individuals accounts for roughly a third of all opioid prescriptions. And just to make the maps clear, in our first map, Wilmington is ranked number 1 at 11.6%, so 11.6% of individuals in Wilmington, North Carolina appear to be misusing opioids. In our second map here, it's ranked number 4 at 53.8%. So what that means is that in our data, in Wilmington, North Carolina, 11.6% of opioid users consumed over half, 53.5%, of all opioids that were prescribed in the Wilmington area. And so in particular interest here, we have 4 cities in Florida that made our top 25 list here. So at number 7, we have Panama City, where 51.6% of opioid prescriptions appear to be being misused. Number 9, Fort Pierce, Florida, where 47.4% of opioid prescriptions appear to be being misused. Number 11, Pensacola, Florida, where 47% of opioid prescriptions are misused. And number 24, Jacksonville, Florida, where 43.7% of opioid prescriptions are being misused. And so I think both of these maps really highlight the geographic clusters of the opioid crisis. And it was particularly worrisome to see that the high prevalence of southern cities and in particular cities in Florida on both of these maps. Next slide, please. So the slides so far have kind of given a very high overview of, in some sense, what's going wrong with the opioid crisis. And so now I'm going to offer 2 recommendations on what could be done. So first, take a segmented and analytics-based approach to opioid misuse. So as we've seen throughout the previous slides, there are many different factors that can add color to the opioid crisis and show how complex it is. And so it's really important, I think, to take that higher understanding and to look more broadly at the opioid crisis rather than simply looking at opioid misuse by itself. Because as we've seen in the previous slides, this is something that's very complex and correlated very highly with a bunch of other factors. And 2, we've also seen that opioid misuse is very related to many other medical conditions. And so I think it's really important to make sure that these other conditions, whether they be behavioral health or pain-related conditions, be addressed appropriately, because in many cases addressing those conditions can have benefits of addressing opioid misuse. And so with these 2 recommendations, we're hopeful that employers can help guide their employees to easily find access to the benefits and other resources that can help them address these 2 underlying conditions. So thank you, and I am happy to take any questions.
Okay, great. Thank you so much, Dr. Whaley. So, folks, please chat your questions to Ashley Tate-Dinger in the chat box. I do actually have some already to go here. So, you had on the slide that had age, and the focus being the baby boomers. Can you talk a little bit more about why you think that would be the case as opposed to the millennials?
All right, so one potential, so overall, just kind of one caveat, is that in the study we did not look at the specific causes, and this is much more to look at correlations. One potential thing that could be going on, though, is that we know that individuals are first exposed to opioids through surgical procedures in many cases, and older individuals are more likely to receive these procedures, and so they may just be more exposed to opioids.
Okay, great. Well, that makes a lot of sense. So, you know, to pick up on your recommendations also, you know, as this collaborative moves forward this year, we'll be identifying data points that the employers can ask their health plans, their PBMs to pull for them in reports. So that will be part of the effort that we undertake this year. So, okay, we have a few questions coming in here. So, a question about the data. What population are the data representative of?
That's a really good question. So this population comes from employers who have signed up for Castlite Health benefits offerings and transparency tools. And so this population is representative of the employer population in general. And so one of the things we did to make sure that the results are valid are to actually compare some baseline characteristics between this population and the general employer population. And they match up almost exactly. And so in this sample, we have data on from about 1 million individuals who are in every single state and geography in the country, and then also from a variety of industries and income groups.
Okay, thank you. So there's a question about wondering whether you know where Orlando and the Central Florida area rank on opioid abuse, and also the Miami area. Those are where most of our employer members are located. Do you know offhand where they may have fallen?
I don't know offhand, but that's the easy point to follow up on.
Okay, great. All right, well, if you can get that to us, we'll share that with everybody. There's a question that I'm not quite understanding. Okay, does the data on dentists surprise you?
So I'm not sure if it was that surprising. I assume that this is the pain-related conditions. And so just one point of clarification. So this isn't necessarily data on dentists. This is people who reported having any type of dental or jaw pain. All these claims are for the medical and pharmaceutical side, and so they don't actually cover dental visits. But how somebody could have gotten that dental and jaw pain code or pain diagnosis is they'd gone to, say, the doctor and complained about jaw pain.
And we find in the data analysis that we do at the Florida Healthcare Coalition that often pretty high on the list of reasons to go to the emergency room for things that could have been dealt with in another setting is dental pain and dental issues. So could be the ER visits as well.
So that could exactly be going on.
Yeah. Please explain the difference between the two top 25 slides. So if we could go back to those again on the differences, that'd be great.
Yeah. So this is a little bit nuanced, and so I appreciate the question. In the orange map here, we have the top 25 of individuals who are misusing opioids. And so, for example, in Wilmington, North Carolina, we see that 11.6% of individuals are misusing their prescription opioids. And so that means that out of all the individuals who have an opioid claim or an opioid prescription in Wilmington, 11.6% either receive both a 90-day prescription or more, and then also receive opioid prescriptions from at least 4 different doctors. Now, if you go to the second slide, the gray slide, or the gray map, what we did is we looked for those people who appear to be misusing their opioids. What volume of opioids do they account for in the entire area? So here you can see Wilmington is ranked number 4 at 53.8%. And so what that means is that the 11.6% of individuals in Wilmington who are misusing the prescription opioids account for over half of all the prescription opioids used in the entire Wilmington, North Carolina area. And so a small number of people are accounting for a very large share of the entire quantity of opioids prescribed.
Okay. How can you identify misuse when the patient's doctor shop?
So one of the nice things that we have in the data is we have doctor identifiers, and so we can see who prescribed the opioids. And so in the medical claims data, we can see if a patient receives opioids from Dr. A, Dr. B, Dr. C, and Dr. D. Now, one thing to note is that all the claims here come through insurance. And so if people are going outside of their insurance company, either through the black market or simply not submitting bills for reimbursement through insurance, we actually don't see their claims. And so in some sense, that makes these findings a little bit more conservative than probably what's going on in reality. And so these findings are pretty stark, I think, but it's possible that it's even worse.
So to pick up on that with what we can and can't see in the data that you analyzed, you mentioned that the dental plan data isn't in there. And were you able to see short-term disability, long-term disability, workers' comp? What was in the data set? Was it just medical and pharmacy claims?
Yeah, so this is just medical and pharmacy claims. But I do think that there's a lot of interesting work to be done on linking opioid use to short and long-term disability claims.
Okay. Question about, back on this map and the one before, there are quite a few large military bases in those locations. Do you think the higher average could be attributed to that? Have you seen anything in the research or, data becoming via Castlight industry-wise? Have you been able to see that?
So that's an interesting question that has come up before, and people have asked about that as well. We are not, we can't quite say. We did notice that many of the areas are pretty close proximity to bases. We don't have any TRICARE or VA enrollees or claims in the data. And so
okay.
if that were the case, it would be, say, coming from family members or others who are who receive insurance through their employers. One potential is that, however, is that the delivery system around the bases becomes treats say military enrollees differently, and so the culture of opioid prescribing may be different in those areas than in other areas.
Okay. Do states? Oh, I'm sorry. Did you want to?
Oh, and so that culture may spill over to the non-military populations.
Okay. Do states that have medical marijuana seem to have a problem?
So I didn't talk about that in the slides today, but it should be in our report. We did see a small difference, but not. We didn't put a causal number onto that.
Okay. Are the findings sensitive to how misuse is defined?
So they're actually not too sensitive, and we one of the reasons that we define misuse the way we did is because we wanted to follow some existing clinical guidelines, and so there are people who have defined opioid misuse prior to that, and we simply leveraged that existing work. We did try different things. So, for example, what happens if we scale, say, the 90-day requirement up or down, or the same with the number of prescribers? And the magnitudes of the results change a little bit, but the overall patterns and the differences across markets actually remain pretty much the same.
Okay, I think this goes back to the maps again. This question says, can you infer that the second slide is assuming multiple drugs per person? So I guess it would be this gray slide.
Yes, and in fact, that is kind of one of the key points of the second slide. That okay. Within these, at least in the second slide, the people who we think are misusing opioids have many multiples more prescriptions than the non-misuse population, even though they're a much smaller population.
All right, a reminder to chat your questions to Ashley. I do still have a few in the queue here. So were you able to see the abuse through the episode of care? Did the use begin in the hospital due to an injury or illness and has not progressed on the prescription drug side?
We did not.
Yeah, it says this is a timeline question, just to frame it.
Yeah, so that's a good question. We did not look at episodes of care. We simply just looked across the study period, what are the broad trends in opioid prescribing behavior.
Okay. Do all of the states in the top 25 have prescription drug monitoring programs? Are there differences between states that do and don't have them?
So that is one of the things we're looking at now. Not all the states have PDMPs. I do believe that Florida has one of the most well-known PDMPs, and we are still seeing relatively high rates of opioid misuse in Florida.
Okay. What are the years of the data?
So we use data from 2013 to 2015. Or sorry, 2014 to 2016.
Okay. So I think that was a lot of questions. I think that's the last of them. If folks have any more, that's all. Okay, I just got a text. That's all. So thank you very much for your presentation. It's a lot of information to absorb. We'll be sending the report that you did with Castlight out. Are there any other resources provided by Castlight that we can connect our employers to? Anything in the works?
We've done work on the opioid crisis, and we'll hopefully continue to update this to look at trends in opioid use in the workforce.
Okay, well, we'll keep you posted on what we do here in Florida and what we uncover. Castlight's one of our affiliate partners, so we'll stay in close touch with Patrick Hale and with you. And thank you very much for your time this morning. I know it's early in Berkeley, California, so we'll let you go and get on with your day. So, again, thanks so much, Dr. Whaley. It was terrific information.
Thank you.
Thank you. All right. So if we could do the next slide. Certainly with 4 of the top 25 cities in the U.S. with the most opioid prescriptions abused being in Florida, that certainly underscores our need to be vigilant in pain management. I don't see the next slide yet. Ashley, are you able to move it up? Oh, well, that's interesting. I can't see it. I don't know if others. are unable to see it.
Carlene, can you see it? Yes.
Oh, okay. So it's me.
Okay. Yeah. Sorry.
So I don't know. I'm having technical difficulties today. Anyway, so through this survey, we wanted to address the employer's knowledge of the most common painful conditions and medication classes that are used for pain within their populations and assess the employer's benefit design, the program offerings, and current workplace policies around the use of opioids. We also wanted to assess resource needs that would allow our employers to better meet the needs of their employees who are suffering from chronic and acute pain. So, as you can see on this slide, a few points that, kind of framed the questions and what we were focusing on with sharing this survey is opioid medications are the most common type of prescribed pain medication used in Florida. However, opioids are not the most appropriate treatment for all of the most common painful conditions. So it's certainly an opportunity to improve there. And the National Business Group on Health did a study and estimated that 60% of adults with substance abuse dependence are actually employed full-time. And that data is from a couple of years ago, so it may be an underestimate since we've seen the trend really starkly increase over the last few years. Also, they saw, and this was in 2014, that 60% of workers' comp claims included opioid medications. And then, as it says here on that last bullet, some industries have a legal obligation to address substance abuse within their employee population. So, again, why we were wanting to find out this information on baseline. Next slide, please. So, reported by the employers who completed the survey, the most frequent painful conditions are on this slide. Number one, and not a big surprise, is low back pain. Number two, other musculoskeletal disorders. Number three, arthritis and other joint pain. And then cancer and angina were tied for 4. And number 5 was migraines and other serious headaches. We did ask the respondents to look at the medical and pharmacy claims data and workers' comp. So in most instances with the respondents, they were able to pull that data from both sides of the house. In some instances, they were not able to provide both. So we're still kind of going through the data to determine, how to interpret the impact on both sides. So next slide, please. So these are opioid-specific responses to some of the questions. So 38.5% of the employers responded that opioids were in their top 10 most frequently prescribed meds. Some did not actually have this information to be able to respond to the question. They didn't have it from their health plan or their PBMs or from workers' comp, whether that is they didn't have it readily available or they don't get those kind of reports. It's certainly an opportunity for us to help put together a list of data points that would be useful to monitor. Half of the employers have quantity limits in place for opioids, so again, a consideration for some of the other employers. This has become a strategy that's been put in place. 42% of the employers have prior authorization requirements, same opportunity there. 67% of the employers reported that employees in their organization are permitted to work while taking a prescription for an opioid pain medication. One of the things that we want to be able to do over the coming year is to identify the policies and procedures that are best practice in the workplace. And so we'll provide that to the employers who are engaged in this collaborative so that they can run that up the flagpole at their own organizations. So this next one's interesting. 3/4 of the employers do not track ER visits for opioid misuse. And a few minutes ago, when Dr. Whaley was doing his presentation, I pointed out, that the dental issue with pain on ER visits, but additionally, it's really important to monitor the data to see if really catastrophic things are happening as a result of opioid use. None of the employers who took the survey have done the calculation to determine the overall cost of an employee who abuses or becomes dependent on opioids. And again, one of the things that we will put together in a toolkit for the employers is how you might construct that estimate and look at strategies to combat that. Next slide, please. So a few more opioid-specific responses. Only a quarter of the employers require the plan members to see a specialist, and those are identified as pain management specialist, a neurologist, an oncologist even, to receive opioid prescriptions for chronic pain. And the question had a little caveat, for example, for longer than 2 weeks. A quarter of the employers provide educational programs on pain management. Half indicated that supervisors are educated on the signs of employee impairment, and a little more than 3/4 of the employers actually do promote opioid reduction by covering post-surgical medications that are an alternative to opioids, but only 17% actually identify their providers in the network as practicing opioid-sparing surgery. All of these points here are opportunities to consider for better pain management. I keep saying the same thing, but again, we will provide guidance and templates to our employers this year for each of these areas. Some of these are really low-hanging fruit, and we feel like they'd be very easy to implement if the employer is interested in doing so. Next slide, please. We wanted to know what kind of educational resources and programming would be helpful to the employers. We did have sort of a top 4 that came out of the data. The first one was a general overview of pain management. We are going to have our next meeting like this on June 13th, and we will be having that be the topic of the educational part of the meeting, along with jumping to what's number 3 and number 4, alternatives for pain management, and also tools for screening for pain or potential for abuse. So those 3 items, number 1, number 3, and number 4, will be covered on our June 13th webinar. In a few minutes, we'll be asking you to chat whether you want to continue to work with us on this and be engaged. We're not going to, continue to inundate you with emails, and if you're not interested. So we're going to ask you to be proactive and let us know whether you want to be continued involvement with us on this. As for number 2, educational programming requested on opioid use and abuse, I think that Dr. Whaley got us started today on understanding the magnitude of the problem, and especially here in Florida. So I think we're on target to address what folks are most concerned about. So let's go on to the next slide. Based on the survey results that I just talked through, actually, you know what? I'm going to stop. I want to see if anybody has any questions. I meant to do that. Ashley, are there any questions on that section?
No, not yet.
Okay, well, let me go on, and certainly stop me if we do, and I'll be happy to answer them. So based on the survey results and the educational information that was requested, we've identified 4 areas of focus for us over the coming year. We're going to have 4 work groups that are going to meet 1 to 2 times, each via conference call or webinar over the year, in addition to the full group meetings like this. But we will primarily communicate via email, so hopefully it won't take too much of your time. The Florida Healthcare Coalition staff will do the heavy lifting, but we need your input as we develop each of the items that will come out of these. The output from these 4 groups will become what we're calling our Better Pain Management Toolkit. The most urgent item, as we understand it from some of our employers, is the education materials for open enrollment. So we'll get that item up first, gain your feedback, and share that at the June 13th meeting. So let me just back up. The 4 work groups, we recognize there are differences between chronic pain and acute care pain, so we want to be able to identify best practices in benefit design, but also we're really moving quickly into alternate payment models in all areas of focus. So there may be some opportunities with bundled payments around pain management, so that group will be focusing on that. I already mentioned the open enrollment materials and in general, employee education materials on pain management. We have already several great resources that we'd like to make available to you. We're going to be setting up a web page on our site for this collaborative, and we'll send you that link, and then you can check in to see if there are resources that you need. Some of them can be co-branded, for example, from Consumer Reports, Choosing Wisely, and some other resources as well. We'll send that link to you as soon as possible. We had a blog that was posted yesterday from Janet Poppy of Passira, and we posted that on our website, on Facebook, Twitter, and LinkedIn regarding post-surgical pain management opportunities, and we've had a lot of social media response back, so that blog will also be archived on the link to the project, and we'll get that to you. So then back to the 3rd item, workplace policies and procedures, and then folded into their productivity issues. There are quite a few resources that if you came to our Disney Best of the Best, and Gay Fortner and Gary Eastis from the city of Knoxville spoke about really important changes that needed to be made in the workplace to prevent catastrophe from opioid abuse and addiction. So we'll be drawing from their work, but also hoping to gain your input on that. And if you were at that presentation, you learned from Gary at the city of Knoxville that the workplace productivity costs are, the loss rather of productivity are far higher than the medical and pharmacy spend for pain management. And then that 4th group will focus on data and monitoring. You know, what data should you collect and receive reports on from your PBM, from your health plan, how you might look at that data. So those are the 4 areas that we've identified. They do overlap a little bit, certainly in some places, but what we'd like you to do is chat to Ashley right now to indicate whether you want to continue with this collaborative, and if so, which group you might like to be involved with. If you need a little more time to consider it, you can email Carlene at flhcc.org. You can certainly email me also at Karen at flhcc.org. But we are certainly very interested in having you be able to provide feedback. You're the boots on the ground, and we want to be able to put together materials that that you can easily implement. So let me go on to the next slide, and again, if you could chat your information. So this meeting today is what we're calling the sort of full group meetings, and the next one is June 13th. I mentioned that, from 11:30 to 1. We'll do that via webinar. Then the next one, we have to identify the date, will be in September. We have our big Best of the Best event in mid-September, so we need to kind of consider that from a bandwidth standpoint. And then in November, we're planning to have a half to three-quarter day face-to-face meeting. We'll be in the Orlando area, in the central part of the state, and that will be really extensive. That's going to really cover all of the detail of what we've been able to accomplish in the 5-6 months, and also do more of a deep dive into pain management strategies. And then again in January we'll have another webinar, and it'll culminate in our annual conference, which will be in April of 2018, with presenting certainly where we've come from the baseline of understanding and changes and what we've been able to produce. So it is a year-long effort. So I think we can go ahead and go on to the next slide and have Lois Adams jump in here and talk to us about how we now have a public health emergency stated for Florida only last week. And let me just, Lois, before you jump in, I attended the work group meeting that was held in Orange County last week, and there were very many state-level representatives, but also local, talking about opioid and heroin task forces that have been taking place over the last couple of years. There were, I think, 3 or 4 other counties where those meetings took place. I think that morning they were in Manatee. I don't know all the other counties that these work groups were held in, but it was really very compelling, and a lot of people got up to the microphone to share their stories. It was interesting to hear what's going on at a state level, but as I mentioned, I think in the welcome, I did not get a sense that there had been any kind of direct connect locally or from a state level with employers and businesses, so I did share that view with some of the key folks there, and they're very interested in engaging with us, providing us resources where needed, and getting any input. So let me turn it over to you, Lois. I don't know if you're muted or unmuted. Are you good to go?
I'm good to go. Thank you so much,
terrific.
Karen. Okay, good. Actually, the emergency order was a product of the Centers for Disease Control declaring a national opioid epidemic, and then therefore Governor Scott went ahead and signed an executive order. We're hearing that word a lot, but he signed an executive order that required measures to be taken to protect the communities and the general welfare of the state. What he actually did with a lot of this was allow pharmacists to go ahead and dispense to emergency medical people naloxone to counteract the effects of overdosage. The pharmacists don't dispense it themselves unless it's upon a written prescription, but they are allowed to provide whatever the EMTs actually do need. Having been in this, so that's where we are, and the executive order lasts for 60 days. It's a $27 million grant that was given by the it was given to the Florida Department of Children and Families, and it was per year for 2 years to prevent the prevention, treatment, and recovery support to address this epidemic, and Governor Scott was smart enough to take advantage of that, because Florida has been, although it is much better than it was, a haven for the dispensing of opioids and prescription narcotics. We've had a lot of work with House Bill 7097, which is the bill that allowed how physicians were going to be able to prescribe this medication and what they were going to be able to do with it. There was a time here in Orange County that they wanted to put all pain specialists out into the industrial complex. Well, that really didn't work, and that didn't make a lot of sense. But I'll tell you, some of these places are the pain management places are not really pain management, but they're a medium to go ahead and just dispense this. Now, I think one of the things, there's a lot of work being done in the area of pain management. There are alternative ways to treat pain, and and not have to use opioids as such. There are external preparations that can be put, and the medication goes directly to a joint, so that it doesn't. You don't have to take it by mouth and it to affect the kidneys and the liver and everything else. It can be put, goes right to the joint and right to the pain and to reduce the inflammation. And there's some time that we need to really have a nice discussion about that. When I hear the prescription benefits managers, in which the employers partake and they contract with a insurance company, and these insurance companies contract with PBMs. The force in the pharmacy, either you do what they want you to do, or you are no longer, a pharmacy is no longer a member of the, to be able to dispense under that health plan. The 90-day supply is just an absolute terror, and especially for opioids. I mean, and we now have a work group of a bunch of scientists who are and Karen, I'll be glad to forward that to you, about the tremendous amount of medicine that has been dumped into our water supply. And I can remember telling Senator Negron at a face-to-face with the legislature that when your little boy starts talking like a little girl, that you're going to understand what I'm telling you about what's happening with this oversupply of medicine. And not necessary. My own son is a physician, and when he tries to dispense something to a patient, and the PBM says they won't pay for it unless it's a 90-day supply. Well, you don't need to have a 90-day supply of a stimulant or an opioid sent to the patient. There's too much that is destroyed. There's one death every week from an overdose of heroin in the state or in the area in Central Florida. And many of it is young children get access to this through their parents' medicine chest. So it's really something. The E-Force, which is our presenter talked about, which is it's actually the computer program up in Tallahassee, in which the physician is supposed to, and they don't always do this, they are supposed to enter into the system those narcotics that have been ordered for the patient, and then when the patient takes the prescription to the pharmacist is supposed to check with that E-Force to make sure that they're not getting it from 4 or 5 different arenas. I've been doing pain management for many years and was director of narcotic controls at Orlando Health for a long time and control the inventory throughout the hospitals. It's amazing what is done. One of the things that the gentleman talked about, and I think you brought it up, were the VA hospitals and the veterans. There is so much oxycodone prescribed at the VA hospitals, only because they're not really treating some of these patients the way they should be treating them so they can get them off it. So they think that, if I just go ahead or if they go ahead and just prescribe these opioids, well, maybe the pain will go away. Not so. And I think that something needs to, look at that. Of course, we've had some problems with the VA hospitals. They're not all bad, but it's certainly a way that they treat the patients to get them, it's not curing anything. So there's a lot of things that I'm glad Governor Scott went ahead and issued this executive order. It allows the freedom to be able to give the compounded or the naloxone preparations to the EMT so that they can take care of it. I would have been happier if they would have allowed pharmacists to go ahead and just dispense it and be able to participate in the emergency care. Excuse me. So that's where we are with this executive order, and I think that's really a good start. And there's a lot more things that I can share with the members of the employer groups on this and about the behavioral health that is a issue with and personality disorders are issues in which they people have become addicted on this. It used to be that we had, there were patients being bussed in from Kentucky and other places. They would go to doctors here in Florida. The doctors would write 5 or 6 prescriptions, and then they would come to the pharmacies. And there were many times when I had 5 scripts in my hand, and or they would call and ask, do we dispense them? Many pharmacies had gotten to the point where, no, they didn't want to dispense them. But it really is an epidemic. It's a horrible epidemic, and it's just a waste of human life.
All right.
And if we need any, I would be glad to help at any other time, and I hope to with things, or perhaps even contribute to your blog.
All right. Thank you so much, Lois. And it, really helps us at the Florida Healthcare Coalition to have your perspective, running pharmacies and seeing what this is all about. So let me go back, Ashley, to that slide with the work groups. There are a couple of people asking to just see those categories again, and there are some questions about that, wanting more detail. I think that probably the best way to deal with sort of the detail of what these groups will be doing is shoot Carlene an email with your specific questions, and then Carlene and I will address them. This is a work in progress. We have some preliminary materials to get people going to react on. There's a lot of existing excellent resources. They're just not out in the, front of everybody's faces. We don't want to reinvent the wheel. So, again, if you could look at those different categories, or if you want to suggest something else that we could work on, we'd appreciate your input on that. This is for you. We want it to be what works best for you. There are also some questions. I said, open enrollment materials. It's not just open enrollment. It would be if you have general employee education. Some of you do newsletters. You have websites, do posters, do educational campaigns and health fairs. We would hope to be as broad as we could. But some employers do actually have education materials at open enrollment. They do it in conjunction with a health fair. And then on the policy end, we realize that that's certainly a long lead time needed for making any changes in an organization. So we just want to be able to, again, provide with you what has been put in place at some employers who've had to deal with this crisis a little bit earlier than we have had to, and that have been effective. And then however long it takes to run it up your flagpole, then that's entirely up to your organization. And then on the data and monitoring, again, to sort of restate that, there are certain codes that can be pulled. We'll be able to provide those to you, and you can ask your health plan, your benefits consultant, your PBM for that information. There's some questions about the time commitment for each. As I said, we'll have 1 to 2 webinar-based meetings. They'll probably be about an hour long over the year. Most of the work will happen via email for you to review what we're presenting to you and get your feedback. So we're trying to minimize the amount of time that it'll take from your busy days. Let's see, I had a few more questions. On the data and monitoring, Ashley Tate-Dinger and I do a lot of the data pulling out of the DeerWalk system. We have a research partnership with the University of Central Florida. So what we're envisioning is that we'll start getting some preliminary sort of benchmark data by the different parts of the state, and if we could match that up to what you all are experiencing to see where there are differences. We could certainly talk about whether there are best practices in place in certain parts of the state or certain employers. But again, the bottom line here is what is the data that you need to have in hand on a regular basis, whether that's monthly or quarterly, that you can monitor to see whether you're seeing any issues or problems pop up. And the other thing about that group is to formulate the questions that you can ask your data. We know that some of you have some of these big data sets, and you have big data and you have those analytics, but we can help you with that, since that's one of the things that the coalition does with different data sets. So I hope that helps. Felt a little bit babbly, but as I said, it's a work in progress. Ashley, are there any more questions on that? If not, we could go on to the last slide, which is the immediate next steps. So again, okay, thanks. Identify your level of interest in participating in a work group and with this larger group. We'll be sending out the recording of this meeting with the PowerPoints, so you'll get the Castlight presentation that Dr. Whaley did and the slides that I presented. We are putting together a link to a web page that would be the collaborative sort of resource landing spot. We're going to be scheduling the work group meetings and the employee education materials. We have some in the works that we want to be able to get feedback over the next month in terms of format and level of detail, grade level wise, the actual content, and hopefully by June 13th, at least our goal is that we would be presenting at that meeting a draft for you to review and consider, and it's up to you entirely if you want to incorporate them into your organization, but that's basically our first deliverable, if you will, towards our toolkit that we'll be assembling and having on that web page. So we are wrapping up a little bit early. Carlene, is there anything that I've left out, since you're the lead managing this? Have I left anything out?
Nope, I think you covered it several times.
Okay. Ashley, is there anything coming up on the chat?
Nope, we're good.
All right. Well, we're going to give you a few minutes back of your time.
Sorry. Hold on one second. Oh, no, sorry. It was just a contact email. Sorry about that. Go ahead. You're good.
Okay. All right. So thanks very much. We're looking forward to working with you. It's obviously very, very important topic for us to get our arms around, and interesting that it coincides with it finally being identified as a state of emergency in the state of Florida. So it's good to be proactive where we can. So thanks again, and we'll talk to you soon. Have a good afternoon. Bye-bye.